diagnosis, we all know 1% of all live births, and the most prevalent or most commonly seen are ASD, VSD, and PDA. The pathophysiology is the abnormal blood flow patterns causing the shunting. And shunting of the blood from either the left side to right or the right to left, and there will be the mixture of oxygenated and deoxygenated blood, eventually which may lead to pulmonary hypertension, paradoxical embolization, and cardiac disease like right ventricular overload or left ventricular overload, resulting into left ventricular dysfunction and right ventricular dysfunction. So the timely diagnosis and intervention can prevent the sequelae. And normal heart anatomy and physiology, you all know, two atria, two ventricles. Between the two atria, there is interatrial septum. Between the two ventricles, there is interventricular septum. And four different valves, tricuspid and pulmonary valve on the right side, and mitral and aortic valve on the left side. And aorta and pulmonary arteries. Aorta gives the oxygenated blood supply to the whole body, and pulmonary artery gives the blood supply to the oxygenated blood supply to the lungs. So there are certain pressure gradients, as we probably already know, that the right ventricular side is usually operating at much lower pressures as compared to the left ventricular side. Right ventricular side, the average pressure or the systolic pressure would be 25 to 30 millimeter of mercury, and in diastole it drops below 3 or 4, because that is the right atrial mean pressure, which allows the forward flow from the right atrium to the right ventricle. And similarly, pulmonary artery or the pulmonary arterial tree, that also operates at the blood pressure of 25 millimeter of mercury. And on the contrary, left ventricular side operates at the systemic blood pressure. That is the our blood pressure what we measure. So that is the 120 in systolic, or even more or less similar. And diastole, again, it has to be roughly around 1 or 2 millimeter of mercury, so that the left atrial blood can forward flow into the left ventricle. So in the left ventricular, diastolic or the mean pressure and diastolic pressure should be 1 or 2 millimeter of mercury. And the contrasting in the blood pressure between these chambers, the right ventricle, left ventricle, right atrium, left atrium, more or less right atrium and left atrium have similar pressures. However, left atrium is slightly more because it operates in a high pressure chamber. So that is what creates this shunting, because the defect of the septum in the atria or the ventricle, or at the level of the pulmonary arteries like PDA or AP window, the gradient happens because of the pressure difference, and the left ventricular side is almost always having a higher pressure as compared to the right side. And then almost always, whenever the shunt is diagnosed, it is left to right shunt, except when it is Eisenmengerized. So we are going to discuss about the theoretical aspect, and then we will discuss, I have some videos of the fluoroscopic images, and then as the sir said, we are going to discuss the tips and tricks, which cases to post for device closure, which cases should be avoided for device closures, because certain cases, they may be operable on right heart catheterization. However, they may not be operable as we see on the transesophageal echocardiogram. So usually atrial septal defect, hole in the atrial septum, ventricular septal defect, almost always ASD and VSD will have left to right shunt, but VSD will Eisenmengerize between the age of 2 to 10 years. Sometimes at the age of 3 or 4 years as well, the patient may be Eisenmengerized, the right heart failure may have set in, and the PA pressure may be suprasystemic, so that the patient's lifespan is reduced, and then there is nothing you can do about it, because once the pulmonary arterial pressure is suprasystemic, there will be right to left shunting. And because of that right to left shunting, the QPQS would be less than 1. And that's when the PVRI would be higher than the SVRI, and PVRI-SVRI ratio would be more than 1. And that's when you cannot operate a patient, because even if you operate, the patient is not going to improve. It will cause further flooding of the lung parenchyma, because there is the hole or the shunt is compensating for the suprasystemic PA pressure by shunting some of the blood to the left side. And if you stop that shunt, if you close that defect, then there will be further increase in the flow towards the pulmonary vasculature that will cause flooding of the pulmonary arteries, and the patient may go into pulmonary arterial edema, congestion, as well as sometimes there will be frothing and hemorrhage as well. So PDA is a persistent duct between the aorta and pulmonary artery, and which usually closes within 24 to 72 hours of birth. So first of all, you have to do an echo and you have to recognize the type of defect, the hemodynamics of the defect, and plan the intervention, whether or not to plan the device as well. So the core principles in device closure from open heart repair, the differences are the open heart surgery is usually cut in the chest, whereas the transcatheter is minimally invasive, so less morbidity, shorter hospital stay, quicker recovery, vascular access, almost always transfemoral. 99% of cases that we have done transcatheter device closure are done by femoral arteries. Imaging guidance is required sometimes with transesophageal echo and fluoroscopy, and most of the time just fluoroscopy and sometimes transthoracic echocardiography as well. The goal of the deployment of the device is to ensure one, complete closure of the defect so that there is no residual shunting, and two, to minimize the complication related to the procedure itself. Remember, whenever you are trying to do an intervention, we must do no harm to the patient. That is the first dictum of interventional cardiology. Whenever you are taking a patient on a cath lab table, you must understand, you must remember what all sorts of complication may happen. How may you harm the patient? Which are the different ways which can cause complications? And if certain complications happen, how are you going to react for that? Because if you have not seen complications, sometimes it's difficult to manage the complications when they arrive unannounced. And believe me, the complications always arrive unannounced. They will never come by, they will never give you a warning. They will never announce that the complication is going to happen in this step or that step. Each and every step of a procedure, the patient may respond differently, patient may move, patient may move her leg, his or her leg, and that may also cause certain complications. So you have to be prepared for each and every step of the procedure. You have to premeditate what complications can happen, what all could go wrong, and you have to have an answer to that. Because if you don't have an answer to that, we have seen many of our colleagues getting brain-fed moment where they don't act in time, and sometimes they lose the patient as well. Because whenever you are doing a structural intervention, the most important thing is that you have to have a surgical backup. You need to have your cardiac surgeon in the hospital, and you need to discuss with him beforehand, before the procedure, that you are going to take this procedure, and there is a less than 1% chance of complication that the device might embolize, or there might be some rent, or there might be some other complication, and the surgeon needs to be on the backup. If not standby, you don't require the surgeon in your cath lab, but the surgeon has to be in the hospital and the backup has to be there, because that will give you a lot more boldness and that will give you a lot more hope that you can attempt the device multiple times without achieving any complications. So first we will discuss about the atrial septal defect. So when to do symptomatic patients for small ASDs, and large and moderate size ASDs should always be closed. When it is left to right shunt, QPQS should be more than 1.5. So 1.5 or even more than that, that is left to right shunt. 1 to 1.5 is bidirectional shunt, and less than 1 of QPQS is right to left shunting. So that means that the pulmonary flow is higher than the systemic flow. Then the defect type, the secondum ASD is the most suitable for the device closures. Primum and the sinus venosus usually require surgical repair, but Now we have devices, specifically the covered stand devices for the sinus venosus type of ASD, specifically superior vena cava sinus venosus type of ASD. Then RV volume overload, dilatation of right atrium and right ventricle are these the uh, indications or suitability for the ASD closure. Anatomical suitability, they say that the defect size should be less than 38 millimeter. I beg to differ. If the defect size is up to 42 mm as well, we have put in device, I personally have put in device, the largest device was 44 millimeter of Lepu memo part or septal occluder. The only thing when you have to put a larger device, you need to look at the left atrial disc and right atrial disc. And if you put in a device of 44, the left atrial disc is going to be 54 or sometimes even more than that. So your left atrium should be roomy enough to accommodate that large left atrial device or the left atrial disc, and the rims should be adequate. You have to prepare on a trans-esophageal echo. I personally recommend that whenever you do an ASD device closure, you should always do a trans-esophageal echo despite the defect being tiny, like 18 millimeter of ASD or 20 millimeter of ASD. That looks certain very tiny on the transthoracic echocardiography. I recommend that you must always do transesophageal echocardiography before you do device closure. Why? Because what you are seeing on transthoracic echocardiography is just one cut section. It may not be enough. And when you look at the transesophageal echocardiography, you look at multiple angles. You look from zero, in which you can see the four chamber view. Then you move towards 45-degree or 60-degree, where you can see the short axis view with the aorta, the Mercedes sign, and then you can see the aortic rim over there. And then you switch over to the 90-degree or 110-degree, depending upon the patient's posture, and where you can see the bicaval view. And in the bicaval view, you can see the superior vena cava as well as the inferior vena cava rim. And sometimes the floppy eustachian wall is also there. People sometimes mistake the eustachian valve as the inferior vena cava or IVC rim as well. So you need to put in your color flow and you need to trace the eustachian valve. It should go beyond the rim and it may go inside the lumen of the IVC as well. So when you see in a transesophageal echocardiography, you should also look for four-chamber view and sometimes the left atrial view to look for the partial anomalous pulmonary venous congestion because connection. So PAPVC, sometimes with superior vena cava type of sinus venosus ASD, there may be PAPVC. And if there is a PAPVC along with an ASD, my recommendation would be to send the patient for surgery. One, ASD surgical closure, and secondly, rerouting of the pulmonary vein towards the left atrium. Because if you don't do that, sometimes people do covered stenting and then we expect that the vein should reroute spontaneously through the left upper pulmonary vein to the left lower pulmonary vein and then to the left atrium. But it is always better to go for the surgery and surgical rerouting of the pulmonary vein so as to improve the oxygenated blood flow of the left atrium. So pre-procedure investigation, as we discussed, history and physical examination, ECG, chest X-ray, transthoracic echo for the primary diagnosis, but transesophageal echocardiography for sizing, imaging, and procedure planning. If it is a tiny ASD, you cannot visualize on a 2D echocardiogram or a transthoracic echocardiogram. You may perform a bubble study. But whenever you are performing a bubble study or a contrast study, it is usually done to ascertain the presence or absence of patent foramen ovale or a PFO. And it is done in patients with paradoxical embolism or cerebrovascular accidents. Hence, the bubble study, whenever you are doing, remember one thing. When you inject the saline, you must always try and do the Valsalva maneuver. Put in the pressure on the patient's abdomen and ask him to strain and ask him to hold breath and try and exhale against the closed glottis. ask him to strain like he is doing in a washroom or toilet. So all these measures can increase the intrathoracic pressure and then can produce the Valsalva like maneuver, and which will help increase the right-sided pressure, which may increase the right to left shunt. And you may see whenever you are injecting that the tiny gush of flow through the patent foramen ovale, and that is the importance of the bubble study or contrast study. Cardiac catheterization. Here we are discussing about cath oximetry or right heart catheterization, as we all may know. What do you do about the cardiac catheterization and how do you perform it? It is useful in cases of ASD, it is useful in cases of VSD, and it is also useful in cases of PDA whenever there is high pulmonary blood pressure or pulmonary hypertension from moderate to severe. Whenever there is a severe pulmonary hypertension, we are in a dilemma whether to close this defect or not, because sometimes if the pressure is suprasystemic, we recommend that if you close the defect, it might cause flooding of the right side of the heart, and it may cause right heart failure, right dysfunction, RV dysfunction, and patient may die. So what to do? We do a right heart catheterization. We perform an oximetry analysis to find out the PVRI, SVRI, QP, and QS. For that, we perform from the right femoral artery or the left femoral artery, one vein. You go to the left ventricle, you take the pressure, you take the sample. You go to the aorta, you take the pressure, you take the sample of arterial blood gas analysis. You go to descending thoracic aorta as well, and you take another sample from that for the arterial blood gas analysis. Then you go to the right side of the heart, you go to the pulmonary arteries first, you take the sample, you take the pressure, you go to the right ventricle, you take the sample, you take the pressure, right atrium, you take the sample and pressure, and you go to the SVC and IVC, superior vena cava and inferior vena cava, for the sample of blood gas analysis. For all practical purposes, SVC and IVC are used for the right-sided samples, because that is they represent the venous side of the sample. And then RA and RV you don't require. Then you need to take the LV and aorta, and sometimes you can also exclude the ascending aorta and directly take the descending aorta, because in the ascending aorta, the sample might differ in case of the patent ductus arteriosus, which is usually located just opposite the left subclavian artery. And if you take from the descending thoracic aorta, you will find and exclude whether the shunting has happened at the level of aorta as well. So 4 samples and 4 pressures usually suffice: SVC, IVC, LV and aorta, and PA, pulmonary artery. Sometimes you can also exclude LV if you're not suspecting of ASD or VSD, but you should take that. Then you go for the calculation with the help of certain formulas. People also have an Excel sheet. If you want, I can share with you an Excel sheet. Then the formulas have already been fed into. You need to check the heart rate of the patient, hemoglobin of the patient, male or female sex, to calculate the VO2 max oxygen consumption of the patient. Then you need to also put in the height, weight, and hemoglobin levels, and then you put in all these pressures and all these oxygen saturation or the SO2 levels from all these blood gas analysis reports. With that, you get the QP-QS ratio. QP-QS more than 1.5, that means it is a left to right shunt. It is a good sign. QP-QS 1 to 1.5, that means it is a bidirectional shunt. Then there is a scope for improvement. QP-QS less than 1, then there is a right to left shunt, and that means that probably it is beyond the repair, the scope of repair. EVRI less than 4 is considered to be the operable. 4 to 8 is the gray zone. And sometimes people say that even up to 8 to 12, you should try the pulmonary vasoreactivity testing. And beyond 12 or beyond 8, you generally suggest that the patient should not be operated. What is this pulmonary vasoreactivity testing? Pulmonary vasoreactivity testing is the 100% oxygen for 15 to 20 minutes, and then you reassess the blood gas analysis and check if the PVRI has reduced or not. If the previous PVRI was 8 to 12, now if it has come down to 4 or 5 or something like that, that means that the vasculature of the pulmonary arteries and the pulmonary arterial tree is still compliant. It is not resistant, and the patient may still improve from the defect closure. Hence, you should check for the QPQS, PVRI, and PVR-SVR ratio. And if you find that in the cardiac catheterization, QPQS is more than 1.5, PVRI is less than 4 or somewhere around 2 to 3, then you should opt for the closure of the defect. Baseline investigation like we do in the pre-angio profile, but you have to have blood group and cross-match prepared, and you need to have a cardiac surgeon on the standby. So patient preparation overnight NBM is generally recommended. Peripheral IV access, sedation as per the requirement, vascular access. So usually they say that only the femoral vein is required for the ASD closure. I personally recommend always take two access, one artery and one vein. Arterial line, you can just put in a 4 French arterial line just for the pressure measurement, because we have seen some complications in which patient developed air embolization while deploying the device and the coronaries were occluded. Patient developed a right coronary artery infarction, and we had to intervene. We had to put in a wire and put in some vasodilators intracoronary, and then the patient improved. So always, whenever you are doing a structural intervention, one artery, one vein has to be there. 4 French artery, 5 or 6 French vein has to be initially taken, and then depending upon the device size, you will require the delivery system. Catheter guidance. So first of all, you have to advance the catheter. Normally, how you do is that I'll show you some videos here. Normally, are the videos visible? Yes, sir. Okay. So normally what we do is we go with a Judkins right or a multi-purpose catheter. We enter into the SVC with the wire, and then we drop down in the left anterior oblique LAO view. Then we cross the defect into the right or the left upper pulmonary veins, trying to avoid the left atrial appendage, and then we put in the wire, the stiff wire. First we just enter with a routine Teflon wire 035, then we put in the stiff wire. Over that we put in the delivery sheet. Here you can see the delivery sheet is there, and the delivery sheet for it was a defect of roughly around 28 mm, so we took a size of 32 millimeter of device. So this is a 14 French delivery system, and this is the device. And the device is attached with a cable. So normally what happens is the device is like a dumbbell. There is a left atrial disc, there is a right atrial disc, and in between you can see there is a handle for the dumbbell. And then with the help of this dumbbell handle, the defect is closed. LA disc and RA disc are just there to prevent the detachment or the embolization of the device into the right or left atria. And on the both side of these two discs, there is a one knob. On the right side, there is a screw. So that you attach a cable with the screw, you tighten the screw on that cable onto that screw, so that when you deploy the device, sometimes you are not happy with the position. So you can again pull it back and then take it out. So here, as you see, the left atrial disc is still a little more ballooning. RA disc is okay. So we tried to recapture, and then again we tried to redeploy the device, and then we confirmed with the echo, and then the left atrial disc started taking a shape. So after that, we performed the Minnesota wiggle. Minnesota wiggle is that you pull the cable just like when you are doing kite flying, so that you try to pull the cable and see if the device is embolizing or coming out or going in or not. So when then you are convinced about the stability of the device, and then you can check with the echo. I always perform transthoracic echo before deploying the device, because the transthoracic echo will give you the guidance on whether the rims have captured or not, especially the superior inferior aortic and the IVC rim. Then you the rotate the cable on the as the cable have a knob, and you rotate it counterclockwise towards you, and within 10 to 12 rotation the device will be detached from the cable, and then you can check on the fluoro, you can check on the echo, and that's how usually we deploy the device. So the fluoro guidance is almost always there, and echo guidance, I perform most of my ASD device closures under transthoracic echo. However, on a certain occasions, I have used transesophageal echo guidance as well, because whenever the SVC or IVC rim is deficient, or the one of the two rim is deficient, then we prefer that the transesophageal echo live guidance should be taken, because if the rim is not adequately captured, then the device might be embolized even after 24 to 48 hours after deployment. So it may look very rosy on the transthoracic echocardiogram. You may not be able to see what is happening. And then on the next day, you go into the round, and then the device is lost. It may either be into the right atrium, right ventricle, or it may have gone into the left ventricle as well. Very rarely it would go to the left ventricle, because the left ventricle is a high pressure chamber with a systolic pressure of 120. So device generally does not move down into the mitral valve to the left ventricle, but it will go into the right atrium, left atrium, and most of the time it is going into the right ventricle. And sometimes it may just rotate inside the atria. So then you have to snare it, you have to capture it in the sheath, and you have to take it out. And then you can put in either a big size device, or sometimes you can just go for the surgical closure. Whenever you cannot recapture or snare the device once it has embolized, then the patient will require a surgery to remove the device and to close the defect as well. The preparation of the device, there are two important steps here, that whenever you are advancing your delivery sheath, that is 12 French or 14 French, it is a long sheath with a dilator, and it is advanced over the stiff wire. At that time, when you take the dilator and the wire out, the mouth of the sheath, the hub of the sheath should be submerged in the water. You have to take a kidney tray, pull it with the normal saline till the brim, and then put the hub of the sheath into the water or saline, and then you take out the dilator and the wire, and you let the sheath back bleed, and then close the valve. Or you cannot just directly take negative suction, because sometimes when you take negative suction, if the valve is defective, you might introduce air, and this air is going inside the left system, so that from the left atrium it may go into the left ventricle brain, and I don't know, anywhere else, because it may cause sudden stroke, it may cause coronary embolization, it may cause peripheral embolization. So de-airing the whole system, and while loading the device, you have, if I am using a 14 French delivery system, we have to use a small sheet of 12 French to load the device. You put in the cable through that small sheath, and then take the device inside into the sheath underwater again, and while continuous flushing of the sheath, so that there is no air captured while capturing the device in the sheath. And then put that sheath, small 12 French sheath, inside the 14 French sheath underwater inside that kidney tray in the saline, and then advance the cable through the 12 French sheath. And once the device has been reached up to high, or means above the iliac bifurcation, then you can take out the 12 French sheath, then push in with the cable itself. The most important aspect is, whenever you advance the device, or whenever you confirm its position, when just the first time the left atrial disc has been deployed, there may be a gush of air or gush of air bubbles which may be released into the left side of the system, which can cause sudden bradycardia or atrial fibrillation, or sometimes it can cause atrial tachycardia. You need to be aware of the situation and you need to be ready for tackling any complication which may arise, because while putting it for the first time, whatever air that was there in the long sheath of the 14 French, because the 14 French means it has a 4.6 millimeter of diameter, so whatever air was there inside that system is totally gone into the left atrium. It may go into coronaries, it may go into carotid, it may go anywhere in the body. So you need to be prepared while first time when you take the left atrial disc out, and then it's stabilized. I think it usually stabilizes and settles within a few minutes. So confirm the position not just with the fluoroscopy. Always do a transthoracic or transesophageal echo. Stability with the help of a Minnesota wiggle. It's like kite flying. When you are flying a kite, you'll just do put in some strain to the thread so that the kite stays in the air. Confirm with the imaging before releasing the device. Release the device and remove the catheters and secure the access. Personally, I believe whenever the 14 French or even higher size of the sheath is involved, I would take a figure of 8 suture on the common femoral vein to achieve hemostasis. But most of the time, what we see is that the cath lab technician or assistant or the helpers in the cath lab, they manually compress the puncture, and it's almost always okay. Venous side is forgiving. It's not like arterial side that even a 6 French puncture, if not compressed properly, can lead to a hematoma, RPH, and whatnot. So normally manual compression and figure of 8 stitch if possible. Then secure hemostasis. Post procedure, at least for 24 hours, observe in the ICU or ward, whatever. Take echocardiogram on the first day, on the day of procedure, and another echocardiogram just for screening on the next day to look for the stability of the device. And almost always give low dose aspirin for first 6 months after the device deployment, because the atria, the right atrium and the left atrium, are both low pressure chambers. And by means of low pressure chamber, I mean to say that there is a stasis inside the atria. And because of that stasis, the Charcot striate may be fulfilled and it can cause thrombosis. So there might be tiny thrombi attached to the atrial septal device. So to prevent that, we continue to give aspirin for at least 6 months after the device until that is endothelialized, and then probably you can stop for 1, 3, 6, and 12 months follow-up visits as we do in all angioplasties, and to look for, because if we put an atrial septal device at the age of 25, 45, 55, we might be able to prevent the paradoxical embolism, and sometimes we might be able to prevent the RV overload and RV dysfunction. But some pulmonary hypertension, some RV remodeling that has already happened over the course of 5 decades is not going to go away overnight. So you might have to give the patient diuretics for the rest of their life, and you might require further checking if the pressure is improving or not. But the echocardiogram 6 monthly, yearly, that's okay. And to check for the device function, you can always do an echocardiogram. And aspirin beyond 6 months, there is no role for that. The complications, what can happen in the procedure, the device embolization, the device, as I discussed, we attach the device through a tiny screw on the cable. Sometimes while pushing the device, the screw is detached. Sometimes the screw is not properly fitted, and that may cause losing the device while deploying the first time as well. How to negate that? Whenever you are attaching the device to the cable, you hear a click when it unlocks. So whenever you are totally turning all the circles, after it's tightly closed, you just try and open it again, and you hear a click when it opens for the first time. And you do it 2 to 3 times. That means that the device is getting securely locked when you are putting it into the lock position. So to prevent that, number one is that. And number two is that whenever you are ready to deploy the device, always do Minnesota wiggle, like a little tumka on that cable, so that you can understand whether the device is stable or not. And number three, whenever you are putting in a device, you should always have a snare in your cath lab. You should never attempt a device closure when you don't have a snare in your cath lab, or you don't have a cardiac OT or cardiac surgeon in your hospital. What other complications that may happen? There is risk of arrhythmias like atrial flutter, fibrillation because of the irritation by the LA disc or RA disc. Monitor the ECG and manage as per guidelines. Pericardial tamponade, it is very rare, but it is a very serious complication. You may, while entering the left upper pulmonary vein or right upper pulmonary vein, sometimes you inadvertently enter the pericardial space. More common if you go with the help of wire, because wire is a hydrophilic wire, and sometimes while entering into the left pulmonary vein, it might tear through them and go into the pericardial space. And when you go through that with the catheter and you put in a stiff wire, that may be life-threatening and catastrophic for the patient. But as we all know, any cardiac procedure, whether it be angioplasty, whether it be TAVI, whether it be pacemaker, whether it be ASD, VSD or PDA device closure, pericardial tamponade or pericardial effusion is one of the complications. You should always be prepared to just put in a transifoid puncture and start tapping and try and do the auto reperfusion. So that whenever there is a pericardial effusion or tamponade, you should always be prepared mentally to tap that, and you do the pericardiocentesis and do the autotransfusion to prevent the hemodynamic collapse. Because the pericardial effusion, if once happened, and if you don't react within 2 minutes or even less than time, the patient may collapse drastically, may have brady arrest, and you may not be able to salvage the patient. Whereas on the other hand, we have seen cases when the SVC-RA junction, because of the rent, there was a large pericardial effusion. We tapped the patient, we sent the patient with autotransfusion into the surgery, and luckily the patient survived. These patients don't always survive. So you have to be careful of your wire manipulation, catheter manipulation, and whenever you are doing any procedure on the heart, you must always be careful that pericardial effusion is a lethal complication, and sometimes the patient do not survive. Residual shunting, tiny residual flow, it's okay, but large residual flow, like sometimes there is a fenestrated ASD, and we put in a normal device, and it is a small size device, it does not cover the other defect, and there may be large residual flow. There are two things that can cause the detrimental effect. One is that the shunting itself may be adequate to cause volume overload and pulmonary hypertension and the Eisenmengerization. Number two is that the residual shunting gives rise to the friction of the blood flow through the device. And if there is a friction of the blood flow through the device, whether it is a ASD, VSD or PDA, there is a high chances of hemolysis. And this hemolysis will present as a cola-colored urine, acute kidney injury 48 hours to 7 days after the device deployment, and sometimes even earlier than that. And then initially the treatment is supportive, but if you believe on the echocardiogram or on the fluoroscopy that the device is causing inadequate closure of the defect, then you can take it out and put in a larger size device. But most of the time, the hemolysis is controllable with the conservative measures, but you need to be aware of that. With the patient of ASD, usually the ASD, VSD and PDA are very comfortable patients and they don't have much complications. Usually we send them to the ward on the same day in the evening and next day we discharge them. But whenever there is an acute kidney injury, whenever there is a cola-colored urine, you need to be wary about hemolysis because of the residual shunting. And on the follow-up, you need to look for the aspirin management and management for pulmonary hypertension and residual RV volume overload. So to summarize, symptomatic or significant shunt must be selected and echo-TEE assessment has to be done. And if you suspect a PA-PVC, then CT pulmonary angiography or cardiac CT must be performed. Procedural steps: vascular access from the most commonly right common femoral vein along with an arterial line just in case, and for BP monitoring as well. Sometimes the sizing can also be done with the help of a balloon, but most of the time transesophageal echocardiography suffices. Then risk and complication like embolization, arrhythmia, residual shunting, hemolysis, access issues, pericardial tamponade, and infection. And the follow-up, a multidisciplinary planning, and the fellows have to ensure the imaging review. Don't post a cardiac structural intervention without showing to your consultants, because even in a hospital, inter-consultant review may be required, because one consultant might believe that the device is the defect is deviceable, and the other consultant might give it for surgery. So you need to keep everyone in the loop. And most important of all, you need to have a snare, you need to be prepared to tap, and you need to have a cardiac surgery backup. Similarly, in the VSD closure, VSD patients are much younger. As I previously told you, ventricular septal defect is a high pressure defect because the left ventricle operates at the pressure of 100 or even more millimeter of mercury. So usually we intervene in the infancy or young adults. So symptomatic infants with failure to thrive in respiratory distress, hemodynamic triggers, left to right shunting causing volume overload, sometimes may present with LV dysfunction and sometimes may present with pulmonary hypertension. And the anatomy matters because the perimembranous or mid-muscular, you can do a device closure, but if it is a subaortic or it's an leaflet, if it is restricted by septal tricuspid leaflet, if it is very near to the aortic valve, then you may require surgical closure. Associated risk of aortic valve prolapse or proximity to the conduction tissue, and contraindication, Eisenmenger syndrome. As we discussed in the cathoxy, if the PVRI is too high, more than 8, more than 12, QPQS is less than 1, then means that it is irreversible. Damage has already been done, and to close the defect is like to kill the patient early. Pre-procedure investigation, as similar to the atrial septal defect, you may not require transesophageal echocardiography, but in certain cases, if you are planning a perimembranous device or sometimes in a subaortic or a high muscular VSD, you should do a TEE to ascertain how far your defect is from the aortic leaflet and length of the aortic leaflet, so that you can prevent any residual aortic regurgitation after the device closure. Cardiac catheterization to measure PVRI, and then the most likely echocardiography. Sometimes there are multiple defects. If there are multiple defects, I recommend that you go for a cardiac CT to check for associated other anomalies of the heart, because sometimes if there are multiple VSDs, there might be another defect in the heart. It might be a PDA, it might be an ASD, there might be a difficult or pulmonary valve problem or branch PA problem. So multiple defect, large subaortic VSD, and with RVOT muscle bundle or something like that, that may require surgical treatment, but cardiac CT should be done as early as possible. So pre-op preparation is similar to that of ASD closure. In pediatric population, we give short general anesthesia. Depending upon the anesthetist, they may give propofol, ketamine or whatever. But the idea is not to intubate, but to give an anesthesia and watch for the respiration, saturation, heart rate, so that the patient does not go into bradyarrest or hypopnea or the desaturation. If that happens, that the anesthetist might intubate, but 90% of the cases in the infants, even at the age of 2 months or 3 months, they generally don't give general anesthesia. One dictum for device closures in the infant is that at least 5 to 7.5 kg of weight should be there, so that device closure can be attempted, because that means that the arterial size of the femoral artery and the iliac is at least 3 to 4 millimeter in size. And for PDA and ASD, we recommend that 10 to 15 kg of weight, it should be there. Usually they attain this by the age of 2 to 5 years of age, and then you can perform the device closure. Even when the VSD patient is having failure to thrive, at least 5 kgs of weight is advisable. Below that, if you want to do a device closure, it is very high risk. And we personally, at our institute, we give it to the cardiac surgeon to do open heart surgery because that is a more controlled environment and they have to do it in the under vision. They directly see the defect, they directly close it. What we are doing in the fluoroscopy is not under vision, it's just like playing with the knobs and just like playing a video game. So the weight criteria for the device closure, like in the ASD or PDA, 10 to 15 kg of weight at least. And for the VSD device closure, ideally 5 kg at least for the device closure. And if it is less than 5 and not growing or the weight is not increasing or recurrent LRTI are happening, then go for a high risk surgical closure. Then fluoroscopy and transthoracic echocardiography. Vascular access for VSD, you will require both the access, femoral artery and femoral vein, sometimes on the same side or the opposite side, depending upon the institutional protocol. At our institute, we do the same side, artery and vein. Then the device selection is usually done with the help of one, that is the 2D echo, and the second, that is the LV angiogram. In the VSD, we do an angiogram. In the PDA, we do an angiogram before the device deployment. We can do sizing and confirmation of the size by the 2D echo. In the ASD, there is no need for the angiogram because it is a low pressure and there will not be anything visible. So the TEE is more helpful over there. So to assess the defect, the margins, and to avoid the valve injury. So VSD occlusion device size as per the requirement either in the angiography or in the echo. Position across the septum. So to close a VSD or to close a PDA, because it is an arteriovenous or the left to right shunting, you need to go across into the other system. So you need to establish an arteriovenous loop or an arteriovenous anastomosis with the help of your wire. You need to cross the ventricular septum without aortic or tricuspid interference. You confirm that, you check the wire, you snare the wire, you take it out, and then you put in your long sheath across the defect, and then you look for the device, release the device, remove the catheters, and close the access sites. So I'll just take you to the video for that. We have a few VSD device. This was a case of a 1-year-old child with not increasing weight. It was a weight of 7.5 kilogram. And we did a VSD device closure for this child. The idea is that whenever you are doing a VSD device closure, you need to be more careful because the child is going to be, the patient is going to be very young. And the procedure sometimes might be very lengthy. And the anesthetists need to be aware of the hemodynamics and they need to take on immediate action whenever that is required. So I'll go one by one. So whenever you take an access in the pediatric population, you must confirm. I usually do pediatric puncture needle and the straight tip J wire and one artery, one vein. It has to be confirmed before putting in a sheath. Punctures are forgiving. The needle puncture or the pediatric puncture needle, all those punctures into the artery or vein, they are forgiving. But if you insert a sheath in the wrong place and then you take it out, then there might be risk of hematoma. At our parent institute, when I was a fellow, we had a complication in a 1-year-old child who had a retroperitoneal hemorrhage and it was diagnosed late into the second day and the patient succumbed. So always, always, always be mindful of your puncture. Never take a puncture if you are not trained for that. And always take your first puncture in the constant supervision of your fellow or the consultants, because this is the most critical aspect of your procedure. Rest, everything is something that you are going to learn one way or the other by time that you grow into your career. But if you don't learn the manners, how to puncture the artery, how to puncture the vein, you are not going to get good results by means of vascular complications, because vascular complications are the second most common cause of morbidity and mortality in patients who are undergoing in the cardiac interventions. So artery and vein confirmed, then we took an angiogram. We can see here is the perimembranous defect. Then we tried crossing it with, and one catheter is in the pulmonary artery. Then I put in the wire through the defect. The other catheter is just for snaring. So we try to snare the wire. We make an arteriovenous loop. We'll take the wire out. And then the arteriovenous loop is established. And with a stiff wire, we just exchange that with a stiff wire. And then we enter the sheath. And you can see that the one wire is coming from the aorta and the other is from the sheath, or the large bore vessel or the large bore access should always be done in the venous side, because the arteries are not that much mature. Then we take the device, we confirm the free movement of the device. This is a Konar MF 8x6 device. So the LV disc is opened, then we take it out, and then we try and open the RV disc. When we confirm it in multiple views, we found that the RV disc was in the RA. So we take it again, we capture it again, and then we go from the right atrium by making a loop. We go from the right atrium by making a loop from above, and then we deploy the right ventricular disc again. And then we take an angiogram just to confirm the procedure, whether the defect has been closed. And then we are happy with that. We release the device by the counterclockwise motion of the cable. Then we take it out. And then we final angiogram just to see the defect has been closed. And this is how the device looks on the floor. So the idea is that whenever you are doing a device closure in the ventricular septal defect, you need to cross the ventricle. Catheter choice, I personally prefer internal mammary artery catheter, that is the diagnostic Lima catheter, 5 French or 4 French, depending. Like in this patient, we use 4 French, otherwise in 5 French. Then you try and poke with the thermo wire, and then at the location of the ventricular septal defect, you enter into the right ventricular side. You can either prepare for snaring beforehand, like I did. We usually keep a catheter with snare ready into the pulmonary artery, because that is something the highest point of where the wire could go into the right ventricle. And even if it does not go to the pulmonary arteries and you cross the VSD, the wire goes into RV or RA or SVC or IVC, you can pull it from the pulmonary arteries and put it into the IVC or SVC, and then snare the wire. Once you have snared the wire, you take it out, because it is to be an extended length, 360 centimeter or 310 centimeter thermo wire. You take it out, and then on the arterial side, you put a clamp, multiple clamps with the artery forceps, and on the venous side, you try and put the the long sheath, that is the delivery system or the delivery sheath for the ventricular septal defect. There are two schools of thoughts. You either take the wire out, or you keep the wire there and then introduce the device. We personally prefer to take the wire out, because when you want to keep the wire inside and then put the device, you need to have a large bore sheath. Like for this patient, we have an 8/6 French, 8x6 device of Konar MF VSD. The sheath or the long sheath was 6 French. But if we have to put in a wire, we may require 7 French or 8 French, because the wire itself is an 035. And then if I have to do that, then I'll require a large bore sheath, which can further detriment in a small patient. But in adult patient, you can always go for a larger sheath, and then you can keep the wire, keep the AV loop intact, and then put in the device from the side. And then that way, you save your time when the device is either not fitting, or the device comes into the right ventricle while deploying, or whenever you are not happy with the position and you want to take it out and you want to go again with another device. So post procedure, overnight observation for 24 hours, check the device position, check the residual shunt, antiplatelet therapies. One important thing with the VSD is that there is a risk of heart block. So you need to give steroids in the first 24 to 48 hours. We generally give Dexona or you can give prednisolone or MPS as well, or hydrocortisone. And heart block because of the conduction system defect, because that area, the membranous septum, is the area where the conduction system lies, and your device might protrude into, and sometimes it may not affect the conduction system, but when the device is deployed, there is some inflammation in the myocardium, and that inflammation can affect the conduction system. So you give steroids, you suppress the inflammation, and that way you can prevent the heart block. And then the complications like device embolization, valvular regurgitation, as I showed you, the risk of our device was in the right atrium, so that there was tricuspid regurgitation. So you have to check if your device or the any of the disc is in across the valve, or if the valve leaflet is impinged, or if there is an aortic regurgitation because of the interference of the device. And you need to have a vigilant post-procedure monitoring for that. So to summarize, which patient are good for device closure? So perimembranous VSD, when you put in a short axis view in the transthoracic echocardiography, if the defect is between 9 o'clock to 11 o'clock, somewhere around there, that is called as perimembranous VSD. If it is beyond that, it might be a tricuspid or subtricuspid, or it might be affecting, the subpulmonic. And if it is below that, it might be subtricuspid. And in the four-chamber view, if you see, if it is directly under the aortic wall and the length of the septum, ventricular septum, from the defect to the aortic wall, if it is less than the aortic leaflet length, that means that the leaflet is going to be impinging. When you are putting the device may be impinging on the leaflet. It may cause torrential aortic regurgitation, and that may worsen the condition. So VSD is by far the most complex of all these three devices, because you have to cross the septum and into the LV, and it is the most irritable chamber, because if you put in a wire, there will be VT, there will be VPCs, and there is continuous run of the premature complexes, and you need to be mindful of that. You cannot continuously poke. You need to take a break if you don't cross within a minute. Then it is a high pressure chamber, so there is a high risk of hemolysis if the defect is not closed properly. There is a risk of heart block, which is not there with PDA, not there with ASD. And by far the last procedure you will learn as a fellow or as a consultant, because nobody is going to give you a VSD device closure on your first day after your DM exam or DNB exam, and nobody is going to teach you how to do a VSD device closure without making you assist them for at least 10 to 20 devices, because that is the complexity. If you don't assist the device first, you will not be able to perform the device alone. So now next is the PDA, patent ductus arteriosus, when to close, when not to close. The similar to that, contraindication is the Eisenmenger or suprasystemic pulmonary arterial hypertension. And the indications are whenever there is an LV volume overload, whenever there is a QPQS is more than 1.5, and whenever there is left ventricular volume overload, LV dysfunction sometimes. If there is an LV dysfunction and the child age is 3 months or 4 months, then again you need to close with high risk. And if the duct is very large, like 6 mm or even more than that, 10 mm, at the age of 2 months, 3 months, then you may need to go for the surgical closure. So patient needs to be, many of our colleagues, they size the PDA by the transthoracic echocardiography only, whereas we do it with the help of transthoracic echocardiography as well as the angiography. And clinical examination to look for continuous murmur, ECG and chest X-ray, transthoracic echo, blood test, routine X-ray, and all the investigations. So there are two school of thoughts. Again, for the PDA, just like ASD, people do it from the venous side, single axis as well, whereas we perform them at arterial venous axis. We like to cross them and then perform the PDA. So patient preparation overnight, 24-hour NBM, that's okay. Then vascular access, artery as well as vein. Catheter navigation, first of all, you take an angiography in the putting the pigtail into the arch of aorta, whereas you can see the shunting from the aorta into the pulmonary artery. And if you want to make sure, you can go in the lateral view, LAO 90 degree, whereas you can directly see the aortic as well as the pulmonary end of the ductus, which can be useful for sizing of the device. And angiographic measurement of the size and shape, if it is too long, tubular, then you may choose ADO2 or sometimes a vascular plug. If it is conical, as it almost always is, you can go with a single ADO or implanted duct occlusion. Sometimes you can go with the rebarb or leg tech or any other duct occlusion as well. So we'll again go to the video first. So in the PDA, I recommend that you go with artery and vein both axes, and then you take an angiogram in the arch of the aorta, and then you try and cross the PDA from the pulmonary side to the aorta. How that happens is that you put in the either in the AP view or the lateral view, and you put in your straight tip Teflon or straight tip thermowire across the multi-purpose angiographic catheter. And then you, in the AP view, you can just try to poke it in the main pulmonary artery and it should go directly straight into the aorta. If it does not happen, like in this case, where we performed this patient, because this patient had slightly restricted PDA, but the patient was a 3-year-old girl with post-stenotic dilatation of the pulmonary arteries, and we cannot cross it from the aorta. So this is how you cross it, either JR or MPA catheter. You put it in the main pulmonary artery and you try and cross with the straight tip Teflon or straight tip thermowire, and it should go into the direction of the pigtail, straight into the aorta. If it does not, then as we did in this case, we try and cross it from the opposite side. We crossed it from the pulmonary side and then we snared it. We crossed it from the aortic side and snared it from the pulmonary side, because you cannot put a sheath from across the aortic side. So then there is a long sheath, 6 French or 7 French, depending upon the size of the device. Then you put in the device. Device has to be freely mobile. It has to be documented in the fluoroscopy by pulling and pushing the device and saving the fluoro. Then you open the left side disc. You take the pigtail down because you cannot keep that entangled. And roughly here you can see this white structure, that is the trachea. And I would say at the anterior and posterior border of the trachea, and that is where usually the origin of the duct or the aortic end of the duct is. So this is anterior, the spine, this is posterior. So this is the anterior border of the trachea. Here is the aortic end of the duct. So while deploying the device, we try and pull the aortic disc at least here till the anterior border of the trachea, and then we open the PA disc. And after that, we check with the angiography, and then we try and remove the device by unscrewing. And then we confirm the position with the angiography as well as with the help of the echocardiography. And while we confirm the location of PDA before releasing, not just the angiogram or just echo, what we check in echo or what we check in the angiogram as well is there may be 2 complications because of the device. One is there may be coarctation. There may be iatrogenic coarctation because of the pulling of the ductal tissue. So post-ductal coarctation may happen. The aorta might be narrowed. And secondly, left pulmonary artery. As you put in your short axis view, the duct usually comes between the left pulmonary artery and main pulmonary artery. It does not almost always never goes into the right pulmonary artery. So in the left pulmonary artery, the flow should be laminar. There should not be any stenosis of the aorta or the left pulmonary artery, because both these complications are catastrophic. They may cause hemolysis, they may cause further symptoms because of the etiology itself. So position the device, angiography check, then check with the echo for coarctation as well as the left pulmonary artery flow. Then you release the device and withdraw the catheter and close the access and ensure the hemostasis. So the post-procedure timeline for PDA is considered to be the easiest of all and the least complex of all device closures, ASD, VSD, and PDA. And at our center, parent center, where I used to study, we have discharged the patients of PDA device closure same day in the evening as well. If you do it early in the morning, like 8 a.m., 9 a.m., we have discharged them by 6 p.m., 7 p.m. And ideally, you should keep them for 24 hours, check the echo next day, and then you can discharge them. Normally, in pediatric population, we don't give a aspirin in the PDA, but in adult, you should give to prevent any thrombosis or atherothrombosis. And you do not require any further follow-up for the PDF, to be honest, but always look for the complications like device embolization, residual shunting, or hemolysis, vessel injury or perforation, vessel injury, coarctation or the aortic stenosis, and left pulmonary artery stenosis. Hemodynamic compromise or vascular obstruction, and then surgery may be required if the device is not achievable. So, to summarize all these three defects, usually ASD is midway, but you will see a lot more ASDs than PDAs and then VSDs. VSDs generally will come to you only when you have a pediatrician in your hospital because most of the patients are either dead by the time they become adult or they are Eisenmengerized. So VSDs in pediatric population only. ASDs, I have personally performed an ASD device closure at the age of 65 years, and that patient was diagnosed because of a recurrent cerebrovascular events. So ASDs may come late in the adulthood, in the sixth, fifth decade as well. PDA usually come in the second, third decade of life because at those time, whenever, even if you don't have any symptoms, you'll go for a pre-employment checkup and somebody is going to put a stethoscope on your chest and they'll find the murmur. And then you'll get diagnosed that, yeah, you have a PDA and then you go for the device closure. So most of the time, artery and vein both access should be taken. ASD and PDA can be performed without arterial access. For PDA, I forgot to mention that how do you perform PDA device closure from the single venous access is that you put in a PA catheter, you put in a pigtail in the PA or somewhere, then you try and cross from the PA because as we showed the PA, the site of the PDA, I'll again try and show it from the videos that the PDA, the location of the PDA on the lateral wall is somewhere here. So you can try and poke from here and then to here, and you can try and poke from that. You can enter the aorta, you can go inside the aorta, you can put in your sheath and dilator into the aorta, and then you keep the wire, you pull the dilator out, and you try and take the sheath out a little bit, somewhere near the anterior border of the aorta, and then you inject the shot. And you inject the dye, and you will see the duct becoming visible. And usually when you are doing a PDA device closure from single venous access, you size them with the echo only. You will not be able to get the exact size from the single angiogram. And then after that, you put in the sheath across the PDA, and then again you will put the device, and then you do it like that. Because of the radiographic marker of anterior border of trachea is almost always coinciding with the aortic end of the patent ductus arteriosus, it is very easy to perform the PDA device closure with a single venous access in very tiny children where the arterial access itself might be hazardous because of the tiny vessels. So vascular access, then the types of devices, atrial septal defect, we have Implanzer, LifeTech, we have Lepu, we have Rivar, another, I think Implanzer is universally available. Then for the VSD, we have perimembranous device as well as mid-muscular device. We have LifeTech and the Lepu devices as well. For the PDA, then again, ADO and ADO2. If the tubular PDA is there, then you have a device with two discs and there is a middle lobe that comes with a cylindrical lobe so that the PDA can be closed. Sizing and imaging, echo as well as the fluoroscopically, and for VSD and PDA, angiographically. And the risk of arrhythmia, embolization, residual shunt, and the thrombus and the pericardial effusion is almost always there. And long-term complications, it is very rare, but patient may have erosion of the device, may have infective endocarditis of the device, thrombus formation over the device. And for VSD and PDA, residual shunting and recanalization, and for VSD, heart block requiring pacemaker, and late embolization. The late embolization may happen 7 days or beyond, and almost always you can snare it out, and when you cannot, you can send the patient for surgery. And PDA used to be previously closed with the coils, and those coils used to get embolized far more than the ductal occluder devices. However, with the devices nowadays are very safe, and I'm most certain that with proper training and oversight, you will never encounter such complications. But you must always be prepared for the complications. As I said, that whenever you are taking a patient for angioplasty, you are mentally prepared for pericardiocentesis. Whenever you are taking for ASD device, you are mentally prepared for pericardiocentesis. Whenever you are doing a femoral angiogram, you are mentally prepared for a hematoma and manual compression. So all these things needs to be born in your mind, that how you may harm the patient and how you will recover from that, because all these complications, these are not happening on a simulation machine, these are not happening in the video game. All these complications are happening on a live patient, and you must always have the compassion and empathy for that. So the advantages of transcatheter device closure, just to summarize: minimally invasive, same day or next day discharge, and no pain, no procedural recovery or rehabilitation required. Patient satisfaction is good. Healthcare burden is less. Cost is also, compared to the open heart surgery, the cardiologists are so poor that they are doing these procedures at minimal or no cost in multiple state-sponsored insurances. And if there are any Q&A, I think we can put in the chat box.
Yeah, well, beautiful talk, sir. And we had a huge attendance of maximum at one time.